Hello and welcome everyone. Today's video is on renal failure which happens in a case of liver dysfunction. The point is many of the times, rather most of the times we think it's hepatorenal syndrome, but there is more to kidney problem in liver failure than just hepatorenal syndrome. So this video will be divided into three parts where we will be discussing various aspects of the liver dysfunction and kidney dysfunction. So we will have 7 cases. We will discuss them along our presentation. This is the part 1 of the video. So there is a liver and kidney interplay. Individuals who have a liver disease, they are susceptible to pathophysiological derangements that lead to a kidney dysfunction. The complexity and the severity of the coexisting liver and kidney pathologies pose a significant diagnostic as well as therapeutic challenge. AKI burden is increasing in hospital patients with decompensated cirrhosis. The incidence is ranging from 20 to 50. Now, patients with advanced cirrhosis and acute liver failure are at risk of developing AKI. The specific conditions covered here are cirrhosis, that is AKI, hepatorenal syndrome, glomerular diseases, hepatorenal syndrome type 2, chronic kidney diseases associated with metabolic associated fatty liver disease of the liver. Next is acute liver failure, the AKI through systemic inflammation, drug toxicity, bile acid induced tubulopathies, acute cholestasis, toxic acute tubular injuries, and post liver transplant AKI, CKD and specific electrolyte disorders. So the main challenge that we face is in measuring the kidney function in liver diseases. How do we know that the patient has a liver kidney disorder? Serum creatinine is the standard test which we do for all patients who have suspected renal dysfunction. But it has its limitation, especially in chronic liver disease cases, because decreased creatinine generation due to sarcopenia. These patients tend to have a low muscle mass that leads to underappreciation of the GFR loss. Interference with calorimetric tests with elevated bilirubin causing variable readings. Serum urea nitrogen also inaccurate as a surrogate of GFR loss. Diminished protein synthesis and metabolism in CLD affect the urea generation. Despite the limitations, changes in serum creatinine day to day in AKI correlates fairly well with changes in the kidney function and remain a valid clinical tool. Serum cystatin C, which is proposed as a better filtration marker because it is less affected by age, the muscle mass of the patient, the liver functional abnormalities compared to creatinine, and it is more accurate surrogate of the estimated GFR. Studies have shown greater accuracy than CKD creatinine in liver cirrhosis patients also, but it does have limitations. The turnaround time for result limits widespread usage. Therefore, serum creatinine and the urea nitrogen is still heavily relied upon and is not something which is very freely and easily available in all centers. So though it's a better parameter, it is not something which is commonly used across the hospitals. Now coming to what are the possible etiologies of acute kidney injury in patients of cirrhosis. First, the most common diagnosis that we make is HRS1, that is HRS-AKI, which is a distinct cause of AKI which is unique to cirrhosis and portal hypertension. You can have pre-result azotemia, but which is again very common in these patients. It can be caused by GI fluid losses, urinary losses, poor cardiac output. You can have ischemic acute tubular injury, which can be because of prolonged pre-renal azotemia, patients being in shock, acute liver failure, acute and chronic liver failure associated inflammations. You can have toxic acute tubular damage, which can be because of cholemic tubulopathy or drug intoxication. Renal vein congestion, which is due to the abdominal compartment syndrome, right ventricular failure, or cirrhotic cardiomyopathy. Acute glomerulonephritis, it is an aggressive form of cirrhosis associated IgA nephropathy. HCV and HBV associated membranoproliferative glomerulonephritis. Acute interstitial nephritis, which can be caused because of the antibiotics that we give. And finally, obstructive uropathy, though rare in these cases, but can occur due to the nephrolithiasis or urinary retention. So every time a patient of AKI comes to us with chronic liver disease, it doesn't mean the diagnosis is HRS. We have a wide range of disorders in the kidney which can happen. So coming to our first case, which will help us in understanding this in more details, is a 42-year-old woman who is evaluated for AKI and has a 2-week history of worsening fatigue. She has alcoholic cirrhosis and reports decreased appetite and diarrhea for the prior 2 weeks. Her current medications include lactulose, carvedilol, furosemide, spironolactone, and aspirin. The dose of lactulose was recently increased. Her temperature is normal and the vitals are essentially normal. The blood pressure is slightly on the lower side. Physical examination discloses dry mucosal membranes. No edema is present on the upper and lower extremities. No venous congestion is noted, and auscultation of the chest is essentially normal both for the heart and the breath sounds. The abdomen is soft and non-tender. No ascites is seen. Lab studies show a sodium of 140, potassium is 4.3, chloride is 95. Creat is 2.3, which the baseline was 0.8. The urea nitrogen is 50. The urine analysis reveals specific gravity of 1.03 and no hematuria or proteinuria. No casts are identified on urine microscopy, and the urine sodium is less than 10 and the urine creatinine is 100. So based on this, what do you think is the most likely etiology of this AKI? Is it acute interstitial nephritis, acute tubular injury, hepatorenal syndrome, obstructive uropathy, or is it a prerenal azotemia? So in this case, the answer is prerenal azotemia. The reasoning is that the patient has a history of alcoholic cirrhosis, which is worsening fatigue, decreased appetite and diarrhea for 2 weeks. So there is a GI fluid loss. In physical examination, you find dry mucosa, no edema, and a volume depleted state. Lab shows elevated creatinine and BAR. The urine analysis has a bland urinary sediments and low urinary sodium, which are all consistent with a prerenal cause of azotemia. So volume depletion is seen, which is common in decompensated cirrhosis. Around 30 to 40% of the AKI cases have volume depletion. These patients are prone to volume depletion because the patient has been, the laxative has been increased, which has caused a diarrhea, and the patient has poor urinary intake, GI hemorrhages, diuretic induced fluid losses. All these can make the patient more prone to volume depletion. Hypoalbuminemia and low effective arterial blood volume is inherent to cirrhosis, increases the vulnerability. Lack of edema and the bland urinary sediment and low urinary sodium are consistent with a prerenal cause. So how do you manage this case? Immediate action is hold medications that can worsen the pre-renal azotemia, that is the diuretics and antihypertensive. The cornerstone is intravenous volume expansion. So you give intravenous albumin in these cases, more effective than normal saline in restoring the blood volume, superior in reducing post-paracentesis circulatory dysfunction, reduced incidence of AKI when co-administered with antibiotic in spontaneous bacterial peritonitis, and it showed faster improvement in hemodynamics and lactate clearance in sepsis-induced hypotension. Albumin formulation, 25% albumin is recommended compared with 5%. 25% requires less cumulative volume and potentially averts the hypervolemia. Both 5 and 25 have sodium concentration similar to normal saline, and they are not salt free, mind you, that must be kept in mind always. Finally, the half-life of albumin is around 16 to 18 hours. So the first diagnosis that we make in most of the cases is hepatorenal syndrome. What is the pathogenesis of this? It is a distinct form of AKI in decompensated cirrhosis. It is triggered by predominance of endogenous vasoconstrictor, elevated hepatic sinusoidal pressures, profibrotic pathways in the damaged liver. These factors cause a maladaptive splanchnic and peripheral vasodilatation, leading to the fall of volume, blood volume. This triggers overactivation of the RAS and the sympathetic nervous system, resulting in hormonal activation, impaired renal autoregulation, causing profound renal arterial vasoconstriction, acute reduction in GFR and AKI. So there is one more thing called the hepatorenal reflex, which is the direct communication between the hepatic and the renal CNS, which can further potentiate the renal hypoperfusion. The precipitating factors are that it accounts for up to 20% of the AKI cases with advanced cirrhosis. Likelihood increases with liver disease progression. Most common precipitating factor is spontaneous bacterial peritonitis. Around 1/3 of the patients with cirrhosis and SBP develop HRS in one study. Other triggers include other infections, GI bleed, and hepatic NSAID. So the diagnostic criteria is by International Club of Ascites, and there is no gold standard as of now. Then the society has this particular criteria, which is diagnosis of decompensated cirrhosis with ascites must be there. AKI according to the Akin criteria. Lack of improvement in serum creatinine after 2 consecutive days of diuretic withdrawal and plasma volume expansion. This is very important. You have to do these things before you can say that the patient has HRS. And there must be absence of shock, and there must be no recent exposure to nephrotoxic medications. There must be no evidence of a structural parenchymal disease. That means there must be absence of casts, overt hematuria or proteinuria, abnormal kidney ultrasound. Urinary sodium concentration should lowering the cutoff from 1% to 0.2 and 0.5 can add specificity. Fractional excretion less than 0.3% is highly predictive. Biomarkers are being used like urinary NGAL, which has shown potential in distinguishing HRS1 from acute tubular injury, but it is not yet clinically available anywhere. Coming to our case, this is a 55-year-old man who has a history of decompensated cirrhosis. Now, this was because of NASH, that is non-alcoholic steatohepatitis. This patient was admitted with abdominal pain and weakness. His current medications are omeprazole, rifaximin, diuretics as in furosemide and spironolactone. His temperature is essentially normal, pulse, respiration, blood pressure are okay. The physical examination reveals jaundice, ascites with diffuse tenderness, 2+ pitting lower extremity edema. Lab studies show sodium of 130, potassium is 4, creatinine is 1.8, baseline was 0.7. So there is clear elevation in the creatinine. Serum urine nitrogen is 35 and the bilirubin is 8.1. Urine analysis reveals no blood or protein. You do find some bilirubin stained hyaline casts, and the urine sodium is less than 10, urine creatinine is 100. The patient receives intravenous albumin 25 grams over 6 hours. The next morning, the patient exhibits worsening of the ascites, oliguria, and further rise in the creatinine, which has gone up from 2.2 to from 1.8. The diagnosis of HRS1 is made. You can correlate with the diagnostic criteria we had shown previously. The patient continues to exhibit worsening ascites. Large volume paracentesis is planned. Now his central venous pressure recorded is 10. Now what is the next best appropriate step you think you can take? Will you start intravenous furosemide? Will you cancel the large volume paracentesis? Will you continue with albumin for more than another 48 hours? Initiate vasoconstrictor therapy and schedule a transjugular intrahepatic portosystemic shunt. So in this particular case, the answer is initiate vasopressor therapy. It is a cornerstone of management. Combination of vasoconstrictor and intravenous albumin is a cornerstone to manage HRS. Induce systemic and splanchnic vasoconstriction to increase the MAP and restore the renal perfusion. Albumin recommended is 1 gram per kg per day, max 100 grams for 24 to 48 hours, with vasoconstriction then 25 grams per day. The vasoconstrictor that we can use are terlipressin and norepinephrine, which are the most effective. Terlipressin is a synthetic vasopressin B1 receptor agonist, which is recently FDA approved for HRS1. It's been the first line in Europe and other regions for now 15 to 20 years right now. Coming to vasoconstrictor therapy options that we have. The first is terlipressin, which is the B1 receptor agonist. It has proven efficacy of almost 20 years. Higher rate of VRS1 removal compared to placebo in the confirmed trial, reduced rate of renal replacement therapy, no need of ISO admission and divided IV dosage. The adverse effects are respiratory failure can happen, abdominal pain and ischemia. Disadvantage is has a very high cost. Norepinephrine, it has alpha-1 adrenergic agonist. It is comparable to terlipressin in small trials. Ease of dose titration is better with this. It has low cost, increased cardiac contractility. The problem with NORAD is that it can cause tachyarrhythmia, restlessness. Disadvantage being it requires a central line and ICU admission. There are some other agents like midodrine and octreotide. They act on various receptors like alpha-1 and somatostatin analogs. They are less effective than the major agents. The evidence is very sparse. They can be used oral and subcut, so the cost is low. Disadvantage is that the efficacy is not very established and they can never be the first line of treatment. Regarding the role of albumin, the concomitant use with vasopressor is seen. The argument for benefit is that one small trial showed greater HRS reversal with albumin terlipressin than terlipressin alone. Caution with overzealous administration is that increased risk of pulmonary edema, which was seen in confirm as well as the ATTAD study. Routine administration without careful volume status assessment may be detrimental. Assessment of volume is challenging in cirrhotic patients. Use history, physical examination, labs and point of care ultrasound. Diuretics can be appropriate as adjunct therapy in HRS1 with hypovolemia. MAP target is therapeutic efficacy of vasoconstrictor is directly related to the MAP increase. Aim for at least more than 15 increase from the baseline. Regarding the transjugular intrahepatic portosystemic shunt, whether we should do it or not, the studies show that the treatment for HRS may be associated with renal recovery in some cases. However, it has its limitation because it's a mostly retrospective trials, uncontrolled and cohort studies which are recommending it. May increase the risk of hepatic encephalopathy. Therapeutic advantage is at the present moment only speculative. So this is a schematic diagram showing the pathophysiology of HRS1. Here you can see the patient has the underlying cirrhosis which causes an imbalance in the vasoconstrictors and vasodilators. So there is this imbalance is both occurring intrahepatic as well as in the splanchnic. In the intrahepatic, there is decreased nitric oxide and increase of the vasoconstrictors, whereas in the splanchnic, there is increased nitric oxide and increased vasodilators. This results in the bacterial translocation, which further increases the nitric oxide. Then you have the splanchnic vasodilatation. This is because of the maladaptive vasodilatation in the splanchnic areas. This results in a decrease in the effective arterial volume. As the vessels dilate, they reduce the effective volume present in the vessels. Despite normal or increased total blood volume, the arteries are still underfilled. This results in the activation of the SNS and the RAS system, which further causes the renal artery vasoconstriction and loss of the autoregulation. Apart from that, you can have the intra-abdominal hypertension because of massive ascites, portopulmonary hypertension and cardiomyopathies. This can cause your renal vein congestion. All these components act to cause something which is called kidney hypoperfusion, which results in acute kidney damage. Thank you for your patience. We will continue with the part 2 and our next line of questions.